sorry for the. So I would like to start by thanking ISSP Gurugram City Branch for giving me this opportunity. Very special thanks to Dr. Achal ma'am for the same. And again, very heartfelt thanks to my seniors at Artemis Hospitals, respected Dr. Ashu Jain sir, Dr. Meenu Gupta madam, Dr. Mohit Gupta sir, and Dr. Aditya Maheshwar sir, who have been constantly supporting me and providing me such inspiration and encouragement all the way. So thank you. I would like to start with the topic. Are the slides visible now, ma'am?
Visible, but you
थोड़ा
can
बड़े में कर
make
दो
it full screen. Make it full screen.
फुल स्क्रीन लो
Full screen to it's okay. Now, ma'am?
अब
now
ठीक है
it's
अब ठीक है
better.
Okay.
Start कर सकते.
Okay.
नहीं, presenter view मत करो. Presenter view नहीं. Full screen ही करो.
अच्छा अच्छा okay ma'am.
फुल स्क्रीन लो
Now okay ma'am.
Now okay. Go ahead.
Okay, so as we know, epidural steroid injections are crucial for managing chronic pain, and they help by treating pain which is caused by irritation and inflammation of the nerve roots. And recently, there have been several reviews and meta-analysis which have shown that these provide reliable pain relief in certain painful conditions. So coming to the intervertebral foramen, as you can see, the boundaries of the foramen are formed medially by the uh, medial margin of the vertebral body, the intervertebral disc, laterally by the articular processes, and superiorly and inferiorly by the pedicles. So this is again another diagram depicting the same. The walls which form the boundaries of the lumbar foraminal space. Superior wall is formed by the rostral pedicle. The inferior wall by the inferior facet. The anterior wall by the intervertebral disc. The posterior wall by the pars intra-articularis, superior articular process, medial wall by the dura, the traversing nerve root, and the epidural fat, and the lateral wall by the psoas major muscle. So in this diagram, we can see the two approaches which are followed during lumbar transforaminal procedures. The first one is the supraneural approach, which is also known as the safe triangle approach. This is the approach which we go for in our institution. And below we can see, of course, the Cambine's approach, which is there. So most commonly in our institution, we follow the supraneural or the safe triangle approach. Okay, the contents of the foramen, the important contents of the foramen are the spinal nerves, the dural root sheath, the lymphatic channels, spinal branch of a segmental artery, and the communicating veins. So coming to the vascularization of the spinal cord, it arises from the aorta mainly via the radicular artery, arising of course bilaterally at the level of each vertebra, and the greatest vascularization is from the anterior spinal artery. So blood supply of the spinal cord, as it can be seen, which has been depicted in this diagram. So the largest segmental artery is the radicularis magna artery, also known as the artery of Adam QX, which comes and supplies the anterior two-thirds of the spinal cord and forms a major blood supply to that region. And it is a branch of the descending aorta. Coming to the basics of corticosteroids, these are basically synthetic derivatives of the endogenous hormones from the adrenal cortex, and they are lipophilic in nature and supplied in suspensions. So what are particulate and non-particulate steroids? So certain steroids stay in suspension, and these are classified as non-particulate. Various others have a depot property which leads to slower absorption and are supposed to act for a longer period of time, and these are known as the particulate steroids. Triamcinolone and methylprednisolone acetate, they tend to precipitate in larger aggregates, and dexamethasone. These have very small size particles, And betamethasone, again, as we'll be seeing in a subsequent slide, they have two forms in the same formulation, which comprises of a soluble and a non-soluble component. Triamcinolone, again, the particles vary in size between zero point 0.5 and 100 microns. Methylprednisolone, again, they have uniform composition, but despite the probability of aggregation being low in these two, there still is a risk of embolism. So coming to dexamethasone,
Kaushik, are you there?
Slide look like
My internet का शायद Kaushik?
particles of dexamethasone are 0.5 micrometer and have a diameter which is 5 to 10 times smaller than RBCs. Dexamethasone is soluble in water with no aggregation property. So it is a solution, and hence it is a potential alternative to the epidural injection of particulate steroids. Second.
Keep going.
Yes, ma'am. The next slide actually is a chart where we have mentioned about the particulate and non-particulate steroids. Yeah, the next one, sir. Yes. So in this chart, we can see the dexamethasone being the non-particulate steroid which is used, and for the particulate steroid, mostly methylprednisolone and triamcinolone are used. So the next slide here we have is depicted the properties of the commonly used injectable steroids, where we can see the equivalent potency of methylprednisolone and triamcinolone to be quite high as compared to betamethasone and dexamethasone. But however, in terms of the relative glucocorticoid potency, dexamethasone is quite high, and in terms of solubility, we can see that dexamethasone is the only one which is among these which is freely soluble, and the acetate form of which, and for betamethasone, there are two forms: the acetate form, which is practically insoluble, and the sodium phosphate form, which is freely soluble. So betamethasone is the agent which comes in two forms, and it is very difficult to predict whether regarding the particles, whether they will have aggregating properties or not. So again, in this slide, what is highlighted here is in the next slide is the regarding the betamethasone sodium phosphate, where again it's shown that the particle sizes are highly variable. So coming to the vehicles and preservatives which are used mostly. So in methylprednisolone and triamcinolone, mostly benzyl alcohol is used as a preservative, and in dexamethasone it is sodium bisulfite and benzalkonium chloride, and of course polyethylene glycol as a vehicle. So coming to whether these agents could cause any complications, what is seen that in the, of course, these are used in much lower concentrations in these solutions, so complications are very rare or next to none. So coming to how steroids work in MIPSI, so they reduce the inflammation which is caused by the compression, ischemia, and they disrupt the PLA2 cascade, phospholipid this cascade, and they reduce the arachidonic acid metabolized, and subsequently reduce prostaglandins and leukotrienes. So apart from this, they have seen to be having a stabilizing effect on the nerve membrane, and they also have been seen to slow down the conduction in C fibers. This may play a role in the analgesic effect. And also they have been found to have some effect on the central mechanisms of pain, thereby reducing the sensitization in the dorsal horn neurons. Also, in addition to this, they may have a direct effect on the CNS by reducing the release of neurotransmitters. So coming to the complications, I have another slide here. Sorry, the next slide maybe, sir. Next one, please, sir. Okay, anyway, the cause of nerve injury has been postulated due to firstly the sustained compressive effect of the injected. Secondly, it could be due to the mechanical needle injury to the vasculature. Thirdly, because of the advancing needle provoking vasospasm of the vasculature. Fourthly, intra-arterial injection and distal embolization of the particulate steroid. And also previous spine surgery, which appears to be an independent risk factor for spinal cord infarction. So the neurovascular complications as such, coming to the cervical region, several case reports, they describe vascular injury after a cervical transforaminal approach, whereas the interlaminar route is related to spinal cord injuries. In the thoracic region, again, there is very little literature to support the incidence of any complications. And in lumbar region, again, several studies have reported injury to the vessels leading to hematoma and embolization. So unintended or unintentional vascular injection, this could lead to direct injection into the artery of Adam-Kivix. And as a result, there could be embolism and infarction of the spinal cord. On the other hand, any material that is directly injected into the abdominal aorta could reach the artery of Adam-Kivix and reach the conus via the collaterals. This could again be catastrophic, as this could lead to stroke or spinal cord infarction and complications such as paraparesis or paraplegia. So next, coming to the evidence, the current evidence and literature, what does it say regarding the use of transforaminal epidural steroid injections? So the first study we have here is regarding the safety of cervical transforaminal epidural steroid injections, which was published in the Interventional Pain Medicine Journal in 2024. So this study was again a huge study in which 6,000 patients were studied in regard to receiving cervical transforaminal epidural injections. And they concluded with the superiority of cervical transforaminal injections with non-particulate steroids over particulate steroids. Next, we have another study, which is the comparison of pain score reduction using triamcinolone versus dexamethasone in cervical transforaminal injection. This study, however, did not find any benefits with either triamcinolone or dexamethasone, which was superior
Kaushik?
Comparison to another.
Kaushik,
Yes, ma'am.
I'm holding you for a second. The slides which are running on screen, no? Make sure whatever you're speaking, just guide Mohit that, it just stays, because we are listening and focusing on the screen, but probably you are reading from some other slideshow. So make sure, you're guiding Mohit.
Actually, I was just elaborating from the slide which is there, ma'am, on screen.
Okay, so make sure that you're speaking from the same slide, okay?
Yes, ma'am, we are in sync right now.
You're in sync, okay, good.
Yes, ma'am. So there was no statistical difference in between triamcinolone and dexamethasone, and both produce similar benefits. So that was what seen in this study. So the next study, it is a review of particulate and non-particulate steroids in spinal epidurals, which was a systemic review and meta-analysis. It was published in the European Spine Journal. Again, this was a huge study which included around 8,000 of literature and papers, and they finally concluded from this that particulate steroids are not demonstratively better in relieving pain, and in view of the concerns over the safety profile, it may be prudent to switch to non-particulates. So the next study we have is from the Journal of Pain Physicians, which is particulate versus non-particulate steroids for transforaminal epidural steroid injections. So this study again was from a group including more than 500 people, where they concluded ultimately that there has to be more studies in terms of finding out about the complications. However, the literature which they pointed out suggested that the particulate steroids offered a slightly better VAS and pain score as compared to non-particulates. Next study we have is the study from Interventional Pain Medicine Journal, which is an update on the technical and safety practice patterns in transforaminal epidural steroid injections. So this study actually included a vast number of senior pain fellowship directors and pain management specialists who studied the effects of transforaminal epidural spinal injections in their private practice from the years of March 2021 to 2022. And in the next slide, we can see that what 91% of the responders they preferred was injection of dexamethasone as compared to 74.5%. In dexamethasone was preferred by 91% responders for cervical transforaminal, and for lumbar it was 74.5% of the responders. So one more study we have, this is from the Agri Pain Journal, where they studied about the comparison of the efficacy of particulate and non-particulate steroids in patients with lumbosacral pain, which were non-operated patients and presented with chronic radicular symptoms. So again, this study, they found that the particulate steroids were far superior to non-particulate steroid. So they included around 130 patients in this study, and it was quite an extensive study and included follow-up of the patients in the short term from 15 days to 1 month, and also in the long term up to 3 months. So they found particulate steroids to be better in the short term. However, in the long term, after a 3-month follow-up, they found that non-particulate steroids were better. So the next article we have over here is from the Journal of the Pain Physicians, which is the epidural intervention in the management of chronic spinal pain, which is of course from the ASIPP, or the American Society of Interventional Pain Physicians guidelines. And this set of guidelines, they included 3 systematic reviews which assess particulate and non-particulate steroids in terms of efficacy and safety. So within this guidelines, Feely et al., they performed the systemic review and meta-analysis, and they concluded that particulate steroids were not demonstrably better in relieving pain as compared to non-particulate steroids. So the next slide, within the same guidelines, Mehta et al., in their systematic review, again concluded that in this study, there was no significant difference in terms of pain reduction in both particulate versus non-particulate steroid while performing cervical transforaminal injection. However, during their study in terms of the lumbar radiculopathy, they found the results were equivocal. So consequently, the authors, they recommended non-particulate steroids pertaining to the safety of the same. So the third and the last report within the same study was by Macker et al., again where they studied a large group of patients, and in which they found out that the visual analog score was, there was an improvement in the particulate group compared to the non-particulate group. However, in the non-particulate group, there was a larger population of patients who had more than 50% of pain relief. So they concluded that the use of particulate steroids as it was, what they postulated was, since particulate steroids seem to be associated with a large number of complications, so clinicians need to weigh their clinical relevance in terms of complications and the risk-benefit ratio. So the next set of guidelines are from the IPM set of guidelines, which is an update of comprehensive evidence-based guidelines for interventional pain techniques. So they studied in this guidelines, they studied about the most common steroids which are used, such as methylprednisolone, triamcinolone, and betamethasone, and they found that the risk of embolization does exist with particulate steroids. And within the same study, Tissot et al., they presented a microscopic picture to illustrate the particulate size of corticosteroids and their potential for embolic microvascular occlusion. And they found a definitive role of corticosteroid in producing particulate embolism. And they concluded that with the literature and with their study, that non-particular steroids could be the agent of choice for transforaminal injections. So the next study which we have, the next slide. Yeah, this is again another static and dynamic microscopic analysis of the corticosteroid injections by McMahon et al., in which methylprednisolone and triamcinolone both were analyzed, and it was dexamethasone was found to be completely soluble, and they demonstrated it to have no microscopic potential to obstruct any arterioles. So again, we have another interesting article which was published in from studies from 4 pain societies in Belgium, Netherlands, and Luxembourg, and they have given 26 considerations and several recommendations. So what they have concluded from this exhaustive study is that they have advised for a negative recommendation for cervical transforaminal injection of particulate steroids. And they have advocated the use of a safe triangle approach for transforaminal steroids, with a preference to keep the needle tip in the posterior of the neuroforamen. Again, they have advised that particulate steroids must only be transforaminally injected at or lower than a level of L3. And of course, this limitation does not apply for dexamethasone. Apart from that, they have recommended for the lowest dose of steroids to be used, such as 40 mg for methylpred, 10 to 20 mg of triamcinolone, and 10 mg for dexamethasone. And on top of that, of course, they have advised for use of contrast and DSA to be optional, contrast to be mandatory and DSA to be optional. And they have concluded that despite the fluoroscopy and with the contrast administration or DSA, there is a chance of accidental intravascular injection, which cannot be ruled out. So what does what do the standard books say about this topic? So this is from the Practical Management of Pain, the 6th edition by Dr. Thomas Carlyle. So what they have mentioned, actually they have quite a few number of guidelines, but I have highlighted the main ones. Can you skip to the next slide, please, sir? Next one, please. Yes, this one. So what they have said that all cervical intralaminar epidural should be performed, of course, with image guidance, and particulate steroids should not be used in therapeutic cervical transforaminal injections. So also, they have recommended a non-particulate steroid such as dexamethasone should be used for lumbar transforaminal epidural injections also, and cervical and lumbar intralaminar epidural steroids to be performed without contrast in patients with documented contraindication to the use of contrast agents. So coming to the next part, which is what does the FDA tell or recommend? Sir, next slide, please. Before that, okay, I think anyways, so the reports of complications which have been published in the past decade was studied extensively by the US FDA in April 2024. And they had issued a warning for the epidural use of steroids. And in this warning, what was emphasized was that the epidural injection of steroids may cause spinal cord infarction, paraplegia, quadriplegia, cortical blindness, and stroke. Hence, they have not officially approved the use of corticosteroids, and they have classified it as a off-label use. Of course, to be used in terms of the risk versus benefit ratio for the patients. So, to summarize this in the next slide, sir, please. Okay, to summarize this, so the use of corticosteroids based on particle size has started an important debate in the treatment of chronic pain. And usually the norm would be solutions with larger particles would seem to be preferred given their longer duration of action. However, multiple cases of paraplegia, conus infarction, quadriparesis being reported. Hence, the available literature would suggest the use of transforaminal steroids in a very judicious way, and most of the literature has leaned towards the use of non-particulate steroids in transforaminal injection. So the take-home message would be in terms of avoiding the devastating complications and adverse effects, the safety of transforaminal and epidural steroids lies on the use of non-particulate steroids. So I would like to conclude. Big thank you to all, and very sorry, ma'am, I got like disconnected in between several times.
Fine, not your mistake.
Connection was not stable. Thank you.
So, thank you, Dr. Kaushik, for presenting. Yeah, Dr. Mohit, go ahead.
Forum is open for any questions. If the participants would like to ask any question, we are open for the questions.
So, while the the people who are participating, they can type their questions in chat box. Meanwhile, we can take Pradeep sir's take on it. Sir,
Yeah.
please. Before and after.
In whole the discussion, there are two or three things, three or four things very important. One is there is no doubt that non-particulate is safer. There is no doubt about it. Question comes key efficacy and the onset of action. Non-particulate is quick action and particulates takes time to act, but the duration of action, the efficacy is much better with the particulate than the non-particulate. Second is which reason what we are doing transforaminal block. For cervical, it is not advised. One should not use particulate. There is no doubt. Cervical region, transforaminal, FDA contraindicated is there. For lumbar region above L2, I think the dexamethasone should be used, and non-particulate should be used above L2 because of the arterial increase, etc. They can cause this. But what I have seen and what has been practiced, and I asked so many people, in fact, those who are practicing transforaminal for last, let's say, more than 35 years, never seen any complication like this. I have seen the trauma, myoclonus jerk, etc. That is there always. I've seen many few complications like neural injury, falling, but not any spinal ischemia or there is some paraplegia or that has not been seen. Whether, and I've asked many people, even in America also, in the conferences there, I do ask what you use. Because, okay, theoretically we say like this, but practically we use methylprednisolone. So little bit I feel, yes, to be safe for the younger people, use dexamethasone. There is a very good effect. There is no problem. There is no medical legal question will come, and the safest is there. But those who are, I don't know, are experienced at the lumbar region below L2, I will try to use the triamcinolone. That's the thing.
Ashu sir, we can have comments from you.
So now, like in cervical area, we don't use transforamin now. it is, I don't think, sir,
Ah,
anybody is
would
practicing that.
contraindicated
I
FDF.
don't think it is done because it is not quality of steroid. It is well said that even the needle pricking the artery can cause cord ischemia. So I don't think anybody is now using cervical transforamen. And in cervical interlaminar epidural steroid, still the recommendations are with the non-particulate. I don't think there is any controversy in that. Correct me, sir, Pradeep sir, if I'm wrong. And now about the lumbar. If you are, I'm talking
Do
first
you use
about.
the dexamethasone, Ashu?
I have never used for last 10 years.
Cervical, I'm talking.
Cervical and lumbar. Thoracic, I have never used particulate now for last 10 years. So we will come to that. As far
How
as
much is the dose?
So we inject 2 milligram of dexamethasone every level.
Dose is still less.
But the variation, what's the literature says
No,
that
so I'll
it's
come to that, sir.
much more for
No,
are using up to 10 milligram and up to 4 to 10 milligram of the dexamethasone.
So what I tell you
in the interlaminar approach.
So no. I was coming to that. If we are talking of recommendation, interlaminar in epidural space, probably you can use particulate steroid above L3 also. There are no clear-cut guidelines for that you should use for interlaminar. I am saying in cervical interlaminar you have to use non-particular for particulate. Non-particulate for lumbar.
Non-particular,
for lumbar, you can use. There is no recommendation as such in present day literature. Even FDA is not very strict about interlaminar. But when we talk of transforamen in lumbar, then yes, now there is a debate about that, and the recommendations are that in transforamen in lumbar area, at least that you were saying around at least up to L3, you should use non-particulate, and below that probably that efficacy issue. But sir, in my practice and in lot of literature like this, our fellow was also talking, there's now good amount of literature which says there is not much of long-term efficacy. Immediate term efficacy can be a difference between a particulate and non-particulate, but the long-term outcome is probably same in both particulate and non-particulate. So my take will be that if the long-term efficacy is same, then probably it is better to use non-particulate in epidural steroid because now I think none of us is practicing interlaminar lumbar. So most of us are doing transforamen only. So we don't use this particulate steroid in any epidural steroid. Now coming to the dose that we were talking, if what we are practicing, if the canal stenosis is not moderate, it is above, mild and above, that there is not much canal stenosis. In all those patients, we are doing epidural adenolysis with saline and this Hylase. So after that, once you release the inflammatory marker, and hyaluronic acid itself is a anti-inflammatory agent. So just we are giving 2 milligram of dexamethasone at every level. Suppose we are doing at 3 level, 2 bilateral, 2 will be 12 milligram. So we are working like that. So total dose is somewhere around 10 to 12 or maybe around that milligram. And it helps very well. But if you are doing volume is no consideration, like 5-6 ml you are doing adenolysis, 7 ml you are doing adenolysis, and then just 1.5 ml of solution with dexamethasone. But if we are giving selective nerve block, like in case of moderate to severe canal stenosis, in that we inject 4 to 6 milligram of dexamethasone in 1 ml at every level, right, sir? So there is a difference between the two. There we don't do adenolysis. So this is what we are doing.
Okay. Raj sir, your take on it.
Mohit.
Sir,
everywhere.
आपकी आवाज कम आ रही है, sir. Your voice.
Okay, I'm using only dexamethasone. Whatever.
Only dexamethasone. Dr. Ashish Chakravarti, sir. Dr. Ashish.
See, उसमें तो there is no doubt. If you want to be safe, then dexamethasone is the best. But if you see the efficacy, what I have seen in the lumbar region, especially if epidural is to be given, then I feel that's the only thing. Otherwise, dexamethasone everywhere, cervical, to everywhere, it is the good thing.
Yes.
Efficacy से आपको मतलब है कि ज्यादा वास्क पेन कंट्रोल आता है या लंबे ड्यूरेशन तक रहता है? What does for with non-particulate?
मेरे ख्याल से देखो, मैं लंबर लोअर लंबर रीजन में ट्राइमसिनोन करता हूँ. Let me tell you very frankly.
No, sir. That's what you shared. But
it is controversial now. It is controversial. If you see the literature, it is controversial.
Sir,
but this thing, it is more of a hype also. Let me tell you very frankly, it is more of a hype. I have interviewed so many practitioners. I've interviewed so many because I was in doubt, because I was using particulate in the lumbar region.
That's why we brought this topic.
And I was also scary why I am not wrong. But people said they say this thing, but they do it in this way for a better efficacy. That's what the dilemma is there. It is what is the more hype, and scientifically you may say something different, and the papers can come out with this thing. But practically, if the efficacy and the relief is concerned, again I'm telling you, relief is concerned, I think in the lumbar region at least, probably I may be wrong, but what I practice is like this.
Sir, what do you use in this?
And I've not seen any complication.
Sir, caudal epidural, what do you give?
हाँ?
Caudal epidural?
क्या चीज?
Caudal epidural, sir?
Caudal epidural में ट्राइमसिनोन करता हूँ.
How much, sir? कितने मिलीग्राम?
40
or 80?
40
milligram. Your sound is breaking up.
Sometimes I do transforaminal also and the epidural also, the combination of the two. Then 20-20 करके अगर एक का है तो 20 transforaminal में करता हूँ, 40 वैसे करता हूँ.
Right.
So we can take Dr. Ashish's comment and then we can go for questions. There are 2 or 3 questions.
Yeah.
Dr. Ashish?
Yeah. Okay. My personal take, head and neck region, and head and neck region definitely. Particulate is strict no. And if it is thoracic, definitely again dexamethasone would be my preferred agent. For lumbar, I almost invariably use particulate steroid. And as Dr. Ashu was asking, for caudal, again particulate. So, and if you ask about my preference for caudal, because I use caudal epidural for wherever there are multiple stenosis. In that case, I'll be giving around 40 milligram of triamcinolone.
So for those who are using particulate, there is one question. Do you prefer triamcinolone, hexaacetonide, or acetate? Is there a difference? Which one is safer? That's a question.
Or we have option. More than a difference, do we have an option?
We usually have triamcinolone acetate, what is available to us, and that is what we use. Yes.
Canacot, right?
सर वो नी वाला आया ना सर, हेक्सा वाला एक.
सर एबॉट वालों ने
वो बात कर रहे होंगे,
पर वो जॉइंट्स के लिए
नी इंट्राआर्टिकुलर के लिए बात कर रहे होंगे.
एसिटेट ही यूज करते हैं ना, एसिटेट ही.
हाँ, पर उसमें नी वाले में प्रोबेबली जितना मुझे याद है 1-2 बार ही देखा है, उस पे लिखा नहीं हुआ फॉर एपिड्यूरल यूज.
नहीं, यहाँ पे मैं I want to say one thing very clearly. The literature which is available with this triamcinolone, it has been very clearly said that they have written this is not meant for epidural use. Now, I talked to a bit person why you have written this warning on your label. So they said there is a not a FDA recommendation. So that's why FDA doesn't allow us to. FDA says us to write this warning on to write on the label,
Particulate thing.
but as everybody said, sir was also saying, cigarette में भी लिखा होता है don't smoke, but everybody is smoking. So,
No, Ashu sir,
that
just a question to you.
yeah.
Is there any particular steroid in which it is mentioned that it should be for epidural use? I don't think any of the steroids.
No. It is not
I
like that.
don't think any of the steroids are recommended for epidural use.
No, it is not like that, Ashish. जो particularly आप literature देखोगे ना, उसमें जो warning mentioned आती है.
I'm talking about the drug information
Drug itself. He's asking
literature.
about like the Dexa ho, triamcinolone ho, या
No,
methylpred
I don't
ho.
think it is on dexamethasone. I'm very clear
Drug
about it.
drug information literature does not mention epidural at all.
No, even in dexamethasone.
Yeah. I don't think it's
It
mentioned
is not
anywhere.
mentioned in any of the steroids that
Yeah.
it can be used as an epidural or
Yes,
intrathecal.
that's exactly what I'm saying.
It is not mentioned in any of the drug literatures. It is only the studies and the research material that can save us if anything goes wrong, that it has been widely used and there are RCTs that they are safe. But drug literature, it cannot save us anywhere.
डॉक्टर रोहित, आपने कोई कॉम्प्लिकेशन देखी है पर्टिकुलेट के
See,
साथ?
many people, just to cut you short, Pradeep sir, many people are using the drug information literature as proof of evidence. So I do not know how far it can, but definitely see, court of law can take anything as a substantial proof of evidence. But if there is any particular literature, that should be held as a stronger evidence rather than the drug information literature.
No, to clarify this, I asked the Abbott head of Kennecott, this.
Dr. Ashish, I just want particulate.
Yes.
I think the warning is only for particulate, not for non-particulate. We have to clarify this. I'll clarify this.
Drug literature comes in the support of the claimant if something goes wrong. But it cannot save us because drug people would clearly say that we have mentioned clearly. So we cannot hold drug company as a third party to the usage of drug into this. If any complication happens, it is between the court and the research material and the doctor who is using it.
Exactly.
And to
exactly
Dr. Pradeep sir's question, sir, no, I have been lucky. I have not faced any complication as per the particulate or non-particulate. Rather, for epidural and caudals, I have never faced any complication of any sort till date. Thank you, sir. That is because of all your blessings and teachings, sir.
Not able to hear. Not able to hear you.
Sir, I said because of your blessings and teachings, by my grace, I have not faced any complications in epidurals till date, whether particulate or non-particulate, sir.
There is a question about particulate. How much dose we use?
Just a moment, Dr. Achal. So basically, one most important thing is whenever you're injecting a dye, whenever you're injecting a dye, it should be in a continuous flow. Most of us avoid doing that. So C-arm, take a shot. Give the dye, take a shot again, and if it is so, meanwhile you have missed the smaller blood vessels in which the dye would have transvasated.
Yeah,
so,
I agree. It should be continuous one. Yes.
Yeah, so it should be the fluoroscope always should be in a continuous flow mode whenever you are injecting the dye. That should be the end point of your deciding whether you are supposed to use particulate or non-particulate in this.
And one must check it, aspirate and see it is not intravascular. That's basically one should be very, very careful.
Mostly you don't get any aspirate.
Yeah,
Still
exactly.
you see the vascular spread.
Yeah. So it is basically when you are aspirating, it is a negative pressure. So because of the negative pressure, the vessels will tend to collapse and you will not have a positive aspirate. But it is the positive pressure which will force the dye inside the smaller blood vessels. So it is the positive pressure injection into the dye and confirmed by live fluoroscopy. That would be more.
Dr. Suvir Thakur, you are asking permission to speak. You can unmute yourself and you can share what you want to share.
Thank you, Achal ma'am. Thank you all seniors. Like Pradeep sir truly said, I think so. I have studied for this as it was my topic during my fellowship. So, long-term steroid repeated use is should be avoided for triamcinolone or particulate steroid. It causes calcification of ligaments. So it should be used for either single time or should be used multiple times only with a great duration between the two sittings. For multiple settings, those setups who are using like there are few medical colleges or centers who are repeatedly using this in settings should be using non-particulate steroid. And as what Ashu Jansar told, truly thoracic it should be avoided because OPLL cases are more the common in thoracic region, and it is hard to detect after OPLL that what patient is being what is the pain generator. And those studies I would say that this recommendation like FDA and other are not recommending because those companies these organizations are also being controlled or funded by medical companies or medical uh, huge market representatives. So if it goes against the rule like uh, what we see in knee replacement, that if we are using PRP or BMAC, TKR being done less. So companies and those orthopedicians are opposing. Same thing for the same reason, and those studies mainly which the presenter told was like after using of particulate steroid or steroid, when this studies were done, these studies were done after doing endoscopy or open surgery. They found that there are particulates in spinal cord or in epidural spaces. So those studies are only considering those patients which they are operating or doing endoscopy. So they find those particulate steroid there itself. So they are against those things. Similar things like FDA, what presenter told that FDA is not approving of steroid use in any of the epidural cases or any spinal cases. Those those FDA studies also that tell that they have not considered any studies for recommendation of that or against that. So they don't recommend at all also. But those complication can be caused by particulate steroid if it is going dural or neurological intra-arterial or vascular conditions. But such things can happen also with surgeries. Any complication can also happen with surgery. So any procedure should be taken care of that it does not cause those complications which can be avoided, like intra-arterial. So rightly Ashish sir what told that it should be in continuous fluoroscopy, which our young pain physicians usually avoid it to decrease their shoots.
So regarding this, what you said, it can cause ligament hypertrophy, the particulate steroids. Do you have any any data for that, or have you heard surgeons saying that, or how do you know?
There are studies. There are
studies which shows that there is ligament hypertrophy.
Yes, ma'am. It causes more canal stenosis, not ligamentum hypertrophy, but canal stenosis or exiting root foraminal stenosis. So those studies doesn't consider that they were already case of stenosis or radiculopathy, back pain, which were being done. So after a failed procedure, they tend to operate it, and then they consider that okay, this might also land up like this. Like in particulate steroid, when we use in knee and orthopedicians operate for TKR, they show us that see these are the things which this steroid is doing, particulate steroid. So that
But we have not come across
See,
this literature
Suvir.
regarding the steroid particulate steroid
Probably you can
causing the
share the
stenosis,
literature
etc.
with us
And
in the
neither in our hospital there are spine surgeons, there are orthopedic surgeons. Nobody has come forward with this allegation. See,
Pradeep
this
sir,
is the ligament that is getting calcified or something like that. I don't know.
Jain sir,
I don't know. Basically, I've not seen the literature.
Pradeep sir,
To
in
find
this
out
one
those
we need to be
studies,
very considerate. How frequent is the frequent we are discussing?
Hello?
sir,
Sir. In this point, we
sir.
need to be very careful and we need to elaborate how frequent is the frequent we are talking here. Is it every 3 days? Is it every 3 weeks? Is it every 3 months? Or is it every 3 years? How frequent are we talking about?
Rohit sir, that's a nice question because there is no particular guidelines. There are only studies that this should be done. Like I have seen, I
No,
won't.
sorry to interrupt you in between. That is what I want to ask. The literature that you are mentioning, that it shall not be used very frequently, and if it is done frequently, it will cause the ligamentum thickening. But how frequent is that frequent? Is there anything of that sort?
So there was not a written publication for that. That's why what I am telling, like few center, I hear about Ahmedabad, like 450 kilometers away from me, and there are multiple patients who goes to Ahmedabad from my city and come back. They tell me that in Ahmedabad Civil Hospital, pain department, they have sealed but not written doctor's name, but they have recommended 5 sittings and one sitting every month, and they have not mentioned the procedure details, they have not mentioned which drug they have used, nothing else. So those are the
Can I cut Dr. Rohit
yes
and
sir.
Shobit?
Yes sir.
So basically, I just want this would be my personal experience. I'm not going by any particular literature, but our usual take is that whenever patient comes, most of the time, if the surgeon sees that it can get healed with interventions alone without requiring surgery, we go for intervention. And if it doesn't help, then the patient goes for surgery. What we have observed in our institute is if the patient has gone an intervention and the surgeon goes ahead and does the surgery later, we have seen particulate steroids to be there in the epidural space for 3 months. 3 months. That is what is our observation, and not once, multiple number of times. So now my usual take is that I would want to avoid, because see, the particulate steroid is already there and it is going to leach out the steroid from there. Okay. So my personal take is if I have injected a patient with particulate steroid, I will not inject the steroid again within these 3 months. Within these 3 months, I would want to continue with my conservative management. If the patient does not improve with conservative management, it would be, I will tell the patient that, see, the particulate steroid is already there. And if I do a second injection, even then you're not going to improve much. So either wait for 3 months or straight away go ahead for surgery.
Dr. Ashish, here I would like to agree with you on this particular point. Even in my practice, what we do is we calculate the dose according to patient's body weight as 3 mg per kg for next one upcoming year. And if it is required, we do not inject that dose in more than 3 doses with at least 3 to 4 months gap. So we keep it in mind that we may have to inject it in 3 different doses. So it is done at least 4 months gap. So I totally agree with you on this point, sir.
Yeah.
Ashish
Another thing, just a moment.
Sir.
Shobit, just a moment.
Yes, sir.
One more thing you asked about the hypertrophy. So regarding that, let me just ask you, why was the injection done at all? Like, for example, if the orthopedician tells you that, see, after you have injected the medication, you have caused OPL. But why was the injection done at all?
This PLL
Right.
was not the part which was this study which I was talking about. PLL was like what Ashu Jain sir told, that in thoracic we used to tend to avoid, and there is a huge
No, so
literature.
we avoid particulate because of the risk of, if you accidentally inject into the veins also, then also it is going to cause a spinal cord infarction.
Yes, sir.
Whereas in lumbar space below L1, L2, the spinal cord ends at conus medullaris, and then you got the cauda equina. So it's not the spinal cord over there. So it is still safer to inject particulate in the lumbar region than in the thoracic or in the cervical. So that is the reason behind you using particulate or non-particulate in the cervical, thoracic, or lumbar region. Not OPLL thickening. I don't think steroid would. And secondly, this orthopedician might show you inside obviously the particulate is still there, but why was the drug injected there? So that
So
it's not because of it's not because of the medicine that the joint has got injured. It is because of the injury that the medicine was injected.
Ashish sir, again supporting your point here, I would like to mention that when we are using this particulate or non-particulate steroid inside, it is because there is a chronic inflammation which would have led to the thickening of the ligaments. So for that, we are injecting an anti-inflammatory drug causing the thickening of PLIs is very, very less chances and very less likely. I totally agree with Ashish sir here.
Agree with you. This is the only thing which I mentioned in my previous comment, that they told the paper published was totally biased. That's why I told you the particulate steroid was that particular paper published was biased. Another thing which Ashish sir told, it's up to our usual setting, what we are taught and we learn and we do is from seniors, that we usually do in 3 months time this procedures, but during there is no particular guidelines for that. We have papers, we have seniors to teach us, but there is no particular guidelines that this patient should be done, this should not be done. I have many patients who had numbness, and I told them to get this done. I told I will do hydrodissection, neuroplasty, epidural steroid. They agreed, and that might not give result. And they had good result, and they are okay, and they are still unfollow because they come with other patients. So I have that 2 years of data with me for few patients. Other than that, there are many patients whom I tell it might not cause relief, so you can go for endoscopy also, and they agree, and I have to do endoscopy for them. That is the.
Excuse me, I wanted to say something, ma'am.
Yeah.
I just went through the United States Pharmacopoeia monograph of dexamethasone sodium, and it can be given IV, IM, and for soft tissue or intralesional use. They have not mentioned epidural anywhere. इंट्रालेशनल में किलोइड्स भी है, इंट्रा आर्टिकुलर भी है, everything.
That's what has been mentioned by other authors as well.
But it's
both for
bursae,
DEXA
tendon,
as well as particulate, they have not given
yeah,
it.
it's off-label use for both.
That we have already discussed, that none of the drug literatures or drug pharmacopoeia mentions that these drugs can be used for epidural anywhere in the studies or even in the literature. It is not mentioned by any of the companies. Even the pharmacopoeia does not mention the use of epidurals.
Rohit sir previously also told true, and now also holds true, because those booklets and those pamphlets which the company people come with, they does not present with actual data. They also hide with data which are not being, those company don't want to publish, but they usually tell you go on to our website. So those websites, like in our practices, we don't tell every patient that it might cause neurological.
But Dr. Suvir, I'll stop you in between here. I agree with your point. There is no truth says what you are saying is right. Absolutely right. What you're saying is absolutely right. But the issue is, in case ever these things go to the court of law, then where do we stand? That is what we are discussing. And for that, we would need a printed literature for which the RCTs come to help. And the drug literature does not help us there. That is what I was mentioning about.
They have drug literature, but they don't come up with drug literature. They come up with pamphlets to distribute. It does not comprises of whole literature. So when we go into detail of literature, they have complication and they present with that. And that then in court of law, they can withdraw their claims that we have literature, you should have gone on our website or such also.
See, actually, in court of law, anything can be used against you. Okay. And if the drug information does not state, or if it does not mention epidural, definitely that can also be used. The onus is upon you to prove whether the drug information literature is wrong or right. So that you can prove only if you have got a strong, RCT-based multicentric study. If it is there, which says that you can use particulate without any contraindication, you are still safe. But then, because there is no, and all these, whatever we are talking about is a large center. Okay, the studies have been conducted, but they have